Okay, good morning, everyone. We've made it. It's the final grand rounds of the calendar year, and we have the pleasure of welcoming Dr. Irfan Karani, who's one of our glaucoma specialists at the Toronto Western Hospital based out of UHN and Trillium Health Partners. Irfan did his training initially in Ottawa, but then came to Toronto to complete the GAS fellowship with Ike, and was then recruited to come on staff at the UHN, and has been there since. It's been a few years now, Irfan,
Yeah.
and I'm excited to hear what's new in glaucoma. It's certainly a very exciting field these days, and we're going to hear about virtual reality and artificial intelligence. And we've got two of our senior residents, Sonia and Jenny, as well. So I'll give you guys the floor. Thank you.
Thank you so much, Amandeep. So I'll just load up my slides here. And so, yeah, thank you to Dr. Curtis, Dr. Slomovic, and Dr. Rai for the invitation to present today. I'm super excited to talk about the history as well as the future of glaucoma assessment and management. And as Amandeep mentioned, this is it's a great end to our calendar year. So with that, my main disclosure I want to present today, and I'm sure Sonia will reference this as well, is artificial intelligence was used in the development of this presentation. It wasn't completely sourced that way, but it was used as an initial basis. And we'll hear more about that from Sonia's presentation. So rather than specifically going through the objectives that we want to talk about, I want to elicit some specific questions I just want you to consider as we go through today's presentation. So the first is, how has the assessment and management of glaucoma changed over the past century? What role can and should virtual reality visual fields take on in the future? And from there, how can artificial intelligence improve the care we provide, but also how can it make the care we provide more complicated? And finally, what's in store for the future? So let's start with the glaucoma journey. So we're not going to go back to kind of prehistoric and medieval times when glaucoma was first thought of or discovered, but really we're going to jump to the 1920s to 1930s, where we really had the assessment and diagnosis of glaucoma based on symptoms that the patient presented with. Management was really based around the surgical iridectomy, as well as a historical use of pilocarpine drops based on with the pilose plant. The surgical iridectomies were largely used in those acute cases of what we now believe to be the acute angle crises, but they were often used in any cases where the pressures were raised in the eye and the eye felt hard. Moving into the 1940s and 1950s, we saw the development of the Schiat stenometer, which, as you can imagine, made things a little bit better. So we had some quantitative analysis that we could use on for intraocular pressures. However, the ability to compare things between patient to patient and the supine position requirements made things still quite challenging. But what we did see, however, was the development of what is still today our gold standard surgery for glaucoma, which was the trabeculectomy. By the 1960s, we saw an increased accuracy of tonometry with the development of Goldman applanation, as well as the development of now more of our mainstay glaucoma drops, namely the beta blockers and the carbonic anhydrase inhibitors. Moving into the 1980s, we saw improved visualization with direct ophthalmoscopy, as well as the first round of automated perimetry. From there, we saw now what is typically our first line agents, namely prostaglandin analogs, and the development of laser trabeculoplasty. But this was in its first form, so namely argon laser trabeculoplasty. Moving into the 1990s, we saw the development of OCT imaging of both the nerve and the macula, courtesy of a lot of our retina colleagues, as well as development further of our laser trabeculoplasties now into selective laser trabeculoplasty, and what was initially thought to be a more successful and safer version of the trabeculectomy, which was the Ahmed glaucoma valve and the Baerveldt glaucoma drainage device. Moving into the 2000s, we saw improved OCTs as well as the establishment of minimally invasive glaucoma surgery, particularly working on in the angle. And the two big ones that we used really in the 2000s were the trabectome, which used a cautery to treat the trabecular meshwork, as well as the first generation of the iStent. Moving into the 2010s, we saw swept source OCT and increased resolution of a lot of our testing, as well as the development of new home tonometry procedures. And finally, what has really been exciting and a really strong jumping off point for glaucoma surgery, namely the development and elucidation of both minimally invasive glaucoma surgery or angle-based surgery, but as well minimally invasive bleb surgery. And so with that, on the MIG side, we saw the recreation and rebirth of the GATT procedure, which we won't go into too much detail with today, as well as the first round of minimally invasive bleb surgeries or subconjunctival surgeries, namely the Zen gel stent. Moving into the 2020s, we see the development of virtual reality visual field perimetry, as well as artificial intelligence that we're going to specifically focus on today, as well as new minimally invasive blood surgeries, namely the Preserful microshunt, which has now been approved in Canada. We are seeing the development and push of what's kind of thought to be an interventional glaucoma mindset, which is this idea of using safer and safer procedures to treat glaucoma patients earlier and earlier, so we never get to the point where we really are requiring our end-stage treatments. So with that, we're going to look at two specific case studies today. The first is virtual reality visual field perimetry, which will be presented by Dr. Jenny Ma, and artificial intelligence in glaucoma management, which will be presented by Dr. Sonia Anshush. And for everyone, I'm going to encourage you to keep an eye out for the Toronto connections. So with that, I will hand things over to Dr. Jenny Ma.
I'll just share my slides. Okay. Well, thank you so much for the introduction and the invitation to present. I'll be presenting on virtual reality visual field testing. So in terms of the current landscape of visual field testing, as you know, visual field testing is essential in the evaluation, diagnosis, and management of ocular and neurologic disorders. And perimetry uses static or kinetic stimuli to evaluate the retina and visual pathway. Two well-known perimeters are the Humphrey visual field and Goldman perimeter. However, some limitations of these current perimetry instruments are that they require a fixed testing environment, have quite long testing times, and the device is expensive. So this spurred the emergence of perimetric testing using virtual reality headsets as an alternative method to measure visual fields in patients. In terms of the current literature on virtual reality-based perimetry, there was a systematic review of current virtual reality-based headset devices published in 2024 with Dr. Vincent from SickKids. And this systematic review found 64 studies describing 36 VR headsets. These VR headsets were used in diverse populations, including neuro-ophthalmic patients, inpatients, monocular patients, and intraoperative patients undergoing awake surgery for epilepsy or tumors. So as you can see, there's a wide applicability of this new technology to many settings. In terms of what this systematic review found, there was variable testing times. So some studies found a shorter testing time by 2.4 minutes compared to the Humphrey, with less false positives and a high reproducibility rate. However, some other studies also found a longer testing duration. So these differences may be due in part to different testing strategies or the efficiency of different VR headsets used across studies. There are also different testing methods that are available. So in the visual grasp mode, the visual field testing is in a manner that's comparable to the Humphrey. Some headsets also use a 240 Hz camera and eye tracking technology integrated into the headset, which has been shown to improve accuracy and reliability by detecting the onset and offset of saccades and gaze direction. So in terms of the types of virtual reality headsets, there are 36 different VR headsets currently published. And there are 7 of them that are FDA approved and commercially available. So here you can see the names of all of the 7 FDA approved and commercially available ones. In terms of the setup on the left, you can see the headset where the goggles are paired with a smartphone that allow for a simulated virtual reality environment. And in testing on the left, patients can wear the headset and their eye movements are tracked on the computer screen. So in terms of the Toronto connection, there's actually a Toronto portable perimeter that was studied by one of our own residents, Dr. Yusuf Ahmed. And this study looked at 150 eyes of 91 patients with an average age of 69 years using a phone, headset, and handheld controller. And this perimeter was assessed for use in glaucoma patients. So in terms of advantages of the Toronto portable perimeter, it allows for visual field testing in various positions and settings, which can be helpful for patients with physical limitations or in remote areas. It is easy to use and does not require trained technicians. So it has potential for use at home or in primary care sites, and has also been shown to have statistically similar test duration and outcomes as a traditional Humphrey visual field. In terms of some limitations, the study found that the false negatives associated with the Toronto portable perimeter were significantly more frequent than the Humphrey, which may raise the possibility of potentially more misdiagnoses. The study did not include healthy control participants, and a larger sample size is likely needed to assess the repeatability of their testing results. So some benefits of this novel technology are that it helps to create a controlled and immersive 3D testing environment. So minimizing distractions and external light interference could potentially affect the test results. It more closely simulates a real life environment, increasing validity. And a VR headset could potentially have a more engaging nature to reduce testing fatigue and may increase reliability as a result. There's also increased portability of using a virtual reality headset, offering advantages of improved accessibility, a flexible testing location to allow those in more remote or underserved areas to undergo a visual field test more easily. And of course, it has telemedicine applications. There can also be reduced testing times, as we've discussed previously as well, and can increase patient engagement in their own healthcare. Furthermore, it is customizable to suit individual patient needs. So using a headset would allow patients to perform a visual field test in unrestricted postures, which can allow this to be more accessible to various patient populations, such as children and elderly patients. So there are also applications of virtual reality perimetry testing to other fields, including visual rehabilitation purposes. So this is a study that looked at the expansion of peripheral visual fields with novel virtual reality digital spectacles. It was a prospective case series of 23 patients using the D-Spec headset to expand patients' peripheral visual field, specifically in glaucoma patients. It found that 18 of 23 patients, or 78%, could identify safety hazards with the D-Spec headset that they could not previously. And it found a statistically significant increase in the ability of patients to identify peripheral objects and in their quantification of the number of peripheral objects. So from this study, we can see that there is a potential for VR spectacles to enhance peripheral object awareness by enhancing the functional visual field of glaucoma patients and potentially improving their quality of life as a result. There are also applications to oculoplastics. So this was a study that looked at superior visual field testing using virtual reality with and without eye tracking for functional upper eyelid surgery evaluation. It was a prospective cross-sectional study of 78 eyes from 41 patients with ptosis, brow ptosis, and dermatochalasis undergoing functional upper eyelid surgery evaluation. They assessed the sensitivity and specificity of superior visual field tests administered using virtual reality spectacles. And from their study, they found a sensitivity of 84.1%, as well as a specificity of 67.6%. So virtual reality may also offer an alternative to standard perimetry for functional upper eyelid surgery evaluation. However, all new technologies have their challenges and limitations. So on this topic, some studies found a decreased precision with increasing visual field damage, which may potentially limit the accuracy and use of virtual reality in more advanced glaucoma cases for disease detection, progression monitoring, and identification of new visual field defects. There were sometimes poor inter-device agreements, and this may exist given the wide array of different VR headsets, as we've talked about the 36 different ones that have been studied, and potentially different testing strategies used across the different studies themselves. There is currently a lack of standardized visual field testing protocols and normative databases for VR-based perimetry devices. So this presents challenges of perimetry interpretation and comparability across different patient populations. There is a cost associated with using the VR headset and the need for more specialized software to undergo this form of testing. In terms of headset design, we should think about compatibility with glasses, device misalignment or shift during testing, and potentially screen distortions. In addition, there is a learning curve that patients may have to undergo with using this kind of headset. So the next question we might think about is, what is the concordance between using a virtual reality headset to do perimetry and standard perimetry? So only a few studies have actually found a high score correlation to gold standard perimetry, so the Humphrey or Goldman, in both glaucoma and more general visual field assessments. So this shows us that there's a need for more validation studies on this topic. The lower correlation between VR headset-based perimetry and Humphrey or the Goldman could potentially be due to administration of the visual field test remotely with a headset device versus in person with the Humphrey or Goldman, and the sort of instruction or clarification that may be offered for either of these testing strategies. There is also a poor point-by-point concordance between using the VR headset and standard automated perimetry for Esterman visual fields, showing that this form of technology is currently unable to be used in a driver's license testing, unfortunately. So what are the future directions of virtual reality that we might look forward to? Currently, there is limited data on validation of virtual reality headsets for use across various conditions and during different stages in glaucoma progression. And we've particularly seen their limitation in potentially more advanced glaucoma as well. So larger validation studies are likely required to examine the correlation of virtual reality headsets compared to the current gold standard of perimetry testing with the Humphrey visual field and Goldman perimeter. In terms of VR headset development, we can look forward to more accurate eye or gaze tracking and improved compatibility with glasses. In addition, longer-term studies to assess patient outcomes and adherence to visual field testing with the adoption of virtual reality headsets would be interesting to look at as well. So these are references. Thank you so much for your time and for Dr. Karani and Dr. Anshush's help with this presentation.
Thank you so much, Dr. Ma, and thank you so much for the commentary to everyone that is providing some thoughts. You know, I see Dr. Lichter, Dr. Reaper, Dr. Cates bringing some information here. Dr. Cates has asked a question just as to whether or not there's been any studies looked at patient preference. And there actually have been a number of studies that have looked at the patient experience of virtual reality visual field testing. And the biggest, I guess, positive that patients report that Jenny relayed was really the comfortability. And so there was a big concern that for a lot of the visual field machines themselves, that they were quite heavy. But even with that the comfortability and ability to sit in various different places made things a lot easier. With that, we will hand things over to Dr. Anshush, who will discuss artificial intelligence.
Hi, good morning, everyone. My presentation is titled Artificial Intelligence's Potential in Advancing Glaucoma Care. And I'd like to thank Dr. Karani for his guidance and feedback, as well as Dr. Ma for her collaboration. So we have no conflicts of interest to declare. These are our learning objectives. First, we'll describe how artificial intelligence can help resolve current challenges in glaucoma management. And then we'll discuss the ethical and logistical implications of integrating artificial intelligence into glaucoma care. So let's start with the basics. What is artificial intelligence? We hear that word often, but what does it mean? Briefly, artificial intelligence is a concept in computer programming where we program computer systems to perform tasks that effectively mimic human cognitive abilities. So think of understanding language, recognizing objects and sounds, problem solving using logic, learning. These are the ideas that are trying to be performed using computer programs when we talk about AI. When we talk about machine learning specifically, that's a branch of AI that uses statistical methods to enable computer systems to improve their performance on a very specific task through experience. And when we talk about deep learning, we're talking about a subset of machine learning, so at the very end of this triangle, that uses artificial neural networks to enable machines to learn from very large sets of data. So in ophthalmology and in glaucoma more specifically, deep learning is a very appropriate way of analyzing image-based data in clinic. Whereas when we talk about non-image data, like visual field data, those are usually interpreted using machine learning software. So in terms of our Toronto connection, a lot of the innovation that has occurred in artificial intelligence actually started at the University of Toronto. Many of you are aware, but Professor Jeffrey Hinton is a professor in computer science at UofT, and he has pretty ubiquitously been described as the father of deep learning. He's made incredibly profound contributions to the field, and his work laid the foundation of modern AI, driving breakthroughs in areas like computer vision, natural language processing, and autonomous systems. His contributions were so significant in the field that this fall, he was awarded the Nobel Prize in Physics. And the prize motivation was for foundational discoveries and inventions that enable machine learning with artificial neural networks. So we're very lucky here at UofT to have that. In terms of glaucoma, I won't belabor the point. I'm speaking to an audience that knows this very well, but glaucoma, very briefly, is a group of diseases that is characterized by damage to the optic nerve, and it's associated with elevated intraocular pressure. It's unfortunate because it's a leading cause of irreversible blindness worldwide, and it's often not asymptomatic until patients develop significant vision loss. And there's a lot of ways AI can actually improve glaucoma management. And these are often the challenges that we experience in treating patients with glaucoma. So we think of early detection, monitoring disease progression, improving adherence to treatment, and improving access to care in areas that are low resources. And as a result of this area of potential, there's been a growing amount of research on this topic. And this is a graph showing the numbers of articles that have researched machine learning as a tool for automated image processing, for example, in glaucoma. So you see that recently there's been a huge surge of interest in this field. Now, when we talk about AI applications in glaucoma care, all we really have to do is imagine a very routine visit to a glaucoma specialist from a patient perspective, or their eye care provider more broadly. They'll walk into clinic, they'll receive ancillary testing, OCTs, visual field, maybe corneal hysteresis. They'll see a technician, they'll get a pressure measurement, a vision, and then they'll see their physician, who will then do a full clinical exam. And at every step of that visit, there is a possibility to implement an AI tool to improve that part of the visit. So when we talk about the acquisition of ancillary testing, OCTs are done very frequently, and AI systems can actually detect very small, minute changes in RNFL thickness that could predict progression before there's even a clinical sign that can be detected at the visit. In the context of a more general eye care provider, an optometrist who sees the patient and is unsure of the diagnosis, fundus photography can be used, and AI tools can classify retinal image as either glaucomatous or normal with fairly high accuracy. When it comes to visual field testing, as we've discussed, there's an element of subjectivity that isn't, required in interpreting these tests, and AI tools can actually reduce that subjectivity and analyze these data a little bit more accurately. And most importantly, there's an element of predictive analytics. So we can use machine learning models to actually predict the likelihood that the patient develops glaucoma, or even more importantly, progresses to advanced stages of glaucoma. And all of this essentially leads to a more personalized treatment plan for each individual patient that accounts for not only their imaging, ancillary testing, clinical data, but also their unique genetic, environmental, and lifestyle attributes. So this slide here demonstrates just how much research is going into the development of AI tools that monitor treatment response. So it's an area of great interest. And the last area is, once the patient leaves the clinic, when they've been prescribed drops and maybe don't have the best adherence to medications for a variety of different reasons, AI tools can predict when patients may miss a dose or are more likely to miss a dose and send a timely reminder. And they can also, there are also other AI-driven applications that can simplify medication schedules or provide virtual assistance for proper drop administration, making the overall process a little bit easier for patients. Now, that all sounds incredibly promising and exciting, and it's clear that there's a lot of people that are interested in this, but I would be remiss to talk about this without mentioning things that we should consider more broadly as a medical community. And these are the limitations of AI programs. We talk a lot about racial bias in these clinical algorithms, but this is something that has been discussed by a lot of different people in a lot of different fields, as you can see. In fact, even Geoffrey Hinton himself, the father of AI, tells us that he's a little bit worried about where this could go. So this leads us to a conversation about the ethical implications of AI in glaucoma care. The big one is bias and fairness. AI algorithms are really only as good as the data sets that they're trained on. And so if the data sets that they're trained on are peppered with a lot of different biases, it's bias in, bias out. And that's something that needs to be front of mind or center of mind for everyone. It's really important to interrogate the diversity within data sets and ensure that there isn't clear underrepresentations of certain ethnic or socioeconomic groups that could only further exacerbate disparities in health outcomes. So when reading literature on this topic, it's always important to see if diversity is mentioned in their data sets. And then there's the concept of hallucination. AI hallucinations are when a large language model, something like ChatGPT, perceives a pattern or an object that is non-existent. So it creates a nonsensical or purely inaccurate output. In other words, these large language models are not infallible. In fact, if you go onto ChatGPT and you go into the message box, the first thing you'll see underneath the message box is a statement by the company stating ChatGPT can make mistakes. So it's important to be aware of that as well. In addition to that, there's the question of transparency and accountability. So much of these complex deep learning algorithms are almost a black box. We can't really figure out how this deep learning model comes to the conclusion that it did. It's hard to understand as a human. And that creates a question. Who is responsible if an AI system makes an error in diagnosis or managing glaucoma? Do we blame the physician? Is the technologist at blame? And currently, there's a real lack of legal precedent regarding this liability. So something to be mindful of as well. And then, of course, there's the question of data privacy. We all know that there are federal laws that protect patient privacy. I'm thinking specifically of the Personal Information Protection and Electronic Documents Act, or HIPAA in the US. So we need to be mindful of how we collect and analyze personal medical data and treat it with the highest level of care to safeguard patient confidentiality. This becomes a little bit complicated because a lot of the people who are making the most amount of progress in this field are private major technology corporations that are fallible as well. And the last thing that should be mentioned, and this is in reference to this article that I've cited here, it's been actually demonstrated that even though we de-identify and depersonalize data in these data sets, it is very possible to re-identify patients after the fact. And so this brings up a whole different set of questions regarding data privacy as well. So in conclusion, AI has the potential to significantly improve glaucoma care by improving early detection, enhancing monitoring, and personalizing treatment. We need to pay careful attention to the ethical and legal challenges to ensure that care is provided in an equitable and effective fashion. And lastly, the University of Toronto is a leading center for AI innovation, and that is a wonderful opportunity for a lot of us who may be interested in doing some interdisciplinary research, kind of bridging the gap between ophthalmology and technology. These are my references, and I'll also say that AI was used in the developing of this presentation. It was used both to create a template, but also to go over papers that I was referencing. If you input in a paper into a large language model like ChatGPT, they can provide you with fairly accurate summaries of that research. You just have to be mindful of hallucinations and always double check, but definitely a neat tool to use when reading literature. Thank you so much. I'm happy to answer any questions, and I'm wishing you all happy holidays. I hope you spend time with the people you care about and enjoy scrumptious treats.
Anush, that was a great presentation. Sonia, sorry. One of the questions, you say the ChatGPT can analyze the article. How would that be better than, let's say, the abstract, which is written by the authors, where you're not worried about hallucinations?
Yeah, absolutely. So I was reading some more dense computer science papers that related to patient privacy, and I was having a hard time understanding the references that were being made. I think there's a certain level of knowledge that is expected when you're reading, these dense articles, in the same way that there's certain expectations in medical literature. And so I was actually pointing out areas that I didn't understand, and then these AI models were able to kind of explain that in layman's terms.
Yeah.
I'm lucky to have friends in computer science as well, so I double checked with them, but it was quite neat as someone who doesn't have a background in engineering or computer science.
Sonia, very nicely done.
Thanks for the question, Ellen, there. So Sonia, my follow-up question to you really is, we often do talk about the difficulties in actually, pulling together our references. And so did you use any AI softwares to pull together your reference list, or have you heard of people actually using the AI systems to format their references systems as they pull presentations together?
Yes, formatting, definitely. In terms of pulling the literature, I think that may be a little bit more challenging. I've tried that in the past and I haven't had as much success. I wonder if you have, but once you find an article that is really good, then it's really great in terms of providing summaries or further explanation. The issue, I think, with pulling literature is hallucinations occur a lot more. At least I've noticed that when I've tried.
Awesome. Thank you. Thank you guys so much. So we're going to shift focus now. And as we come kind of to the closure of our presentation today, we're going to look at really what's in store for the future. And so as we look forward, we've talked a lot about at previous presentations, as well as at our different symposia, about the role of angle-based minimally invasive glaucoma surgery, as well as subconjunctival or minimally invasive bleb surgeries. Now, in the past, if we recall, we had a previous device that was called the SiPass that directly connected the anterior chamber to the suprachoroidal space. And unfortunately, having Alan here is probably a benefit here, given a lot of changes to the endothelial cell count. That device was actually pulled from the market by Alcon voluntarily. So the role for suprachoroidal surgery, where we connect the anterior chamber to the suprachoroidal space, is still very much being evaluated. And the first one that we want to speak about is the mini-ject that is produced by iStar. So we're lucky here in Toronto with the team at Prism. There was actually part of the initial trials for the development and approvals for the iStar mini-ject. So it's a porous material that is kind of owned and patented by the company itself. So after creating a controlled cleft in the anterior chamber that connects the anterior chamber to the suprachoroidal space, this specific kind of patented material is placed into that cleft and connects the two chambers together. So the idea is, we talk a lot about the past how clefts can reduce pressures for a significant amount of time, but once they close up, we see pressure spikes. This is a way to keep that cleft open in a controlled fashion. So again, this is the Mini-Ject iStar. It has been FDA approved and is currently in usage in the US. The second one we'll bring up is what's called the AlloFlow or Lantrec. So similar to what we talked a bit about before, in this case, the device does not come with a controlled cleft. So you create the cleft yourself as the surgeon, and then input a scleral-like material that connects the anterior chamber again to the suprachoroidal space. So once again, the idea is you're creating a small cleft, and in doing so, keeping it open with a scleral-like material that helps to reduce pressure. Now, we are still really not sure in the long term what the risks are of the spaces closing, because it is very much a potential space. As we recall, the suprachoroidal space is not normally an area where we can have fluid draining there regularly, or it's not a true space, but it is a potential space, but we don't know how long that potential space can potentially stay open in the future. Kind of second big area that we could talk about is the ability to create titratable bleb surgery devices. And so I can say I was really excited while I was in fellowship. We had the opportunity to actually implant one of the first iWatch devices. And so this was a similar to a tube drainage system like the Bearvault or the Ahmed that we currently have. This is a tube system that connects the anterior chamber to the orbit further back. And we use what was called the iWatch pencil, which actually helped to titrate this device open and closed using magnets. Now, the device is not fully on the market, and some of our first experiences were not amazing with this device. We actually had to open it up pretty much all the way fairly quickly, but it did prove, it was a good proof of concept that there is potential for titratable bleb surgery devices in the future, which leads us to a really exciting potential in the future, which is the Calibre eye. And this is a titratable shunt, again, that is silicone-based, where it has a nitinol valve that actually sits in the anterior chamber. And it's titratable because we use, our normal retinal lasers to open and close two specific valves that are within the implant itself. And so this allows us the ability to control for high IOP as well as hypotony by opening and closing, because unlike other potential titratable devices, this is actually reversible. And so if you find that you want to increase the pressure, you want to decrease the pressure, you simply have to have access to a retinal or argon lasers to open and close this device. And so the potential for this is honestly quite astounding. And we are lucky as well to be starting off some trials looking at this device in the future as well. Third, this is a machine that's actually already approved and is currently on market. So Belkin Vision, which was recently purchased by Alcon, developed what we call a direct SLT. So our traditional and conventional SLTs used a gonio mirror, typically a Latina lens, for example, to transmit and reflect the SLT laser into the anterior chamber angle to right specifically at the trabecular meshwork. With this device, there is no lens, so there's no discomfort of putting the lens on the patient's eye, and the patient sits in the device, and once they're positioned, the laser is applied to the whole trabecular meshwork. Again, you can choose the number of spots, the number of treatments you wish to use, but they happen all simultaneously. And so what was, typically I do 100 shots for my SLTs. This becomes, rather than 100 shots, it becomes once the patient is positioned, you can treat all of the trabecular meshwork all at once. So great potential for efficiency as well in the future, and reducing our dependence on drops with increased ability to offer SLT. Finally, I want to look at a new type of femtosecond-based procedure. So VLA's company has developed what's called the femtosecond laser image-guided high-precision trabeculotomy. So for those of us that work with Dr. Schlenker and myself and other the glaucoma specialists, where we do a lot of gonioscopy-assisted transluminal trabeculotomies, or GATT procedures, this allows us the ability to perform a trabeculotomy or a connection and treatment of the trabecular meshwork itself without actually doing any incisional surgery. And so we use that same femtosecond laser, but we apply it to the trabecular meshwork. And currently right now, a lot of the research is looking at the size of the trabeculotomies that we create. So for example, currently when we do our incisional surgeries, we're using either a 90 or 180 degree opening into the trabecular meshwork, or a 360 degree treatment. But here we have the ability to actually, very carefully decide exactly how large of a trabeculotomy we wish to create. And as well, the concern for things like blood reflex are much reduced because there's no pressure changes during the surgery itself. So the potential is again, outstanding. Finally, again, not to end on maybe a negative note, but I do want to talk a bit about the glaucoma tsunami that we are anticipating in the future. So looking at the global prevalence and glaucoma projections up into 2040, what we are finding is anywhere from a 40 to 60% increase in the number of patients that have glaucoma. And with that, not only are we complicating those factors further is not only the number of patients, but also the desire to have this interventional glaucoma mindset where we want to treat our patients earlier with safer and safer procedures and interventions, whether they be medical, laser, or incisional. And so with that, as we come to an end, I want to stress the importance of continuing to have ongoing glaucoma conversations between all members of the eye care and healthcare professional teams as we recognize the increase in prevalence and incidence of glaucoma that we are expecting in the future. With that, to just review, we've summarized the changing nature of glaucoma practice as it pertains to both assessment, diagnostic imaging, as well as intervention. We've reviewed the benefits, challenges, and opportunities posed by virtual reality visual field testing and perimetry. And we've described how artificial intelligence can help resolve current challenges in glaucoma, but also the ethical and logistical implications of integrating artificial intelligence into our glaucoma care. And we've outlined some exciting upcoming glaucoma interventions. So with that, thank you again to everyone, and I wish you the happiest of holidays and have a great rest of the year. With that, we are open to any questions, and I'll turn it over back to Dr. Slomovic and Dr. Rai.
Great, thank you, everyone. Those were great presentations. There was a question in the chat about the eye watch and the ability to have an MRI for that patient.
So good question. So my understanding is, and again, I would have to confirm this, but the valve mechanisms itself are not specific, like they're not classic iron-based metallic devices. I think I'm not sure if they use, our other devices use nitinol. I can't remember exactly what the material was, but from our understanding, it is totally fine in MRIs because it's not our classic, I guess, magnetic-based metals. It's a different nitinol material. So it should be okay.
Thank you.
Irfan,
yeah.
Oh, sorry. Go ahead, Amandeep. I'll ask after you.
No, for sure. You go first.
Thank you. You mentioned this tsunami of glaucoma, and it sounds very real. Is this based on aging population, better diagnostic modalities? Why do we see this? Is this there already and we're just not picking it up? Or is this an aging population that's going to be more prone towards glaucoma?
So I think it is all of the above, with maybe the exception of we don't totally know if our prevalence is increasing on a per capita basis. So from the first factor that you referenced is an aging population. So just simply by having an aging population, our prevalence of glaucoma will increase naturally. But in addition to that, the diagnostic imaging has become so much better in the last 20 to 30 years that we quickly reviewed today that we are catching patients who never would have even realized that they had glaucoma in the first place. And so often our patients, because it is in many cases an asymptomatic disease, they don't even realize it until often the very, very end. And finally, the third thing is, we could maybe diagnose glaucoma early, but our ability to provide safe intervention early was very different, 20 years ago than it is today. And so often we're talking about, cataract surgery, for example, as an opportunity to treat glaucoma in pretty much all situations for patients that have any signs of glaucomatous optic neuropathy. Just that sheer volume of patients who could receive early intervention to help prevent progression in the long term is, again, another hugely complicating factor in this dynamic process.
You're talking about a demographic that's vulnerable. These are elder patients going for cataract surgery.
Absolutely. But it's also an opportunity. So we don't want to lose that opportunity as well to do something to help further stabilize their glaucoma. And our studies have very clearly shown that reducing fluctuations with intervention vis-a-vis drops, for example, that these interventions, even with consistent IOPs, have shown a reduced rate of progression in the long term. So our ability to use intervention in a safe way for our patients earlier and earlier is further increasing that population that we want to serve.
One last question. Seeing a lot of glaucoma drop toxicity, are you seeing any shift towards more SLTs being performed as a primary procedure? I mean, our traditional teaching was you start with drops and you go to laser.
Mm-hmm.
I think we're reevaluating that. Do you see a shift in that?
Yeah. So, I mean, maybe you're speaking a bit to someone who's already converted, but my first line treatment in pretty much all open angle cases, with the exception of maybe normal tension glaucoma, is SLT, especially for my younger patients, especially with a lot of the complications that we see with prostaglandin usage over 20 to 30 years. SLT pretty much is as much as possible my first line treatment. And the role that we have now with potential direct SLT for, a 2-minute procedure that can save us off drops for, 2 to 5 years, that potential, again, increases us even further from an efficiency standpoint. So absolutely, SLT is a great, great option. It doesn't work in everyone, but it's a great option. And really, I would encourage everyone to use SLT as their first line treatment rather than drops, obviously, when indicated.
Now, how many times, let's say you have somebody who's responding to SLT, how many times can you repeat that?
Good question. And so there are two different answers I would give you here. The first answer is what our studies have shown. And so, it's clear that SLT can be, easily used, a full 360 degrees on at least 2 occasions. So I typically start off with 360-degree treatments. And so I will generally offer a total of 2 rounds for patients that have no other complications. That being said, I'm quite early in practice, and so that may change with time. Finally, and this is something I learned from Dr. Schlenker when I was in fellowship, was, if you're planning to take someone to surgery for fairly large incisional surgery, would you not offer SLT for a 3rd time with the hopes that maybe it might have an effect given how effective it could have been in the past? And the answer for me is, if I'm planning to take someone to surgery and they had a response to SLT in the past, even if they've already had it twice or even 3 times, I will consider and, perhaps recommend to the patient that we trial SLT for a 3rd or 4th time with the hopes of delaying or preventing incisional glaucoma surgery.
Thank you.
Right. I think Dr. Schlenker had some question of why do some people, Matt, I think he's been added as a panel.
I think it was more of a comment, but I brought him
Perfect, yeah. And so, the comment there from Dr. Schlenker was, why do some people like drops versus SLT? And it maybe feels as though this idea of empowerment, they are doing something for their own benefit. And so maybe home tonometry might be a way to help that empowerment in the future. And Dr. Ahmed has said that finding challenges for cost and access for a lot of these treatments definitely is a concern for sure. We talk a bit about direct SLT as an amazing option for the future, but some of these companies are now, using user fees. And so every time you use the laser, there's a cost associated with it, which was not typically how we used lasers in the past.
It seems everyone's going to subscription-based models.
Yep. Totally right about that.
Matt made a good point here about home-based monitoring. And I was wondering earlier, like if patients start to take this VR headset home and they buy their own, right? There's going to be a huge burden of phone calls to offices about, I think I have progression, right? Any thoughts on that? And my other question is, there's a comment from Michael Reeb.
I think we just lost our connection there with Amadip. So I'll answer the first portion there with regards to home tonometry home measurements, as well as connections to home tonometry as well. And interestingly, we have not seen a huge spike in patients requesting earlier appointments. We do have some patients that have home tonometry, for example, and they are able to see the results themselves. But usually most people, have taken into account that information and use it in a way that is effective for their treatment moving forward. With regards to visual fields, we're really lucky. So Dr. Trope worked pretty actively. We have a great medical student, Bill Shee, who's actually looked at home tonometry devices actively in our clinic. And patients love the ability to recheck their visual fields on an ongoing basis. And they find that that ability for them to play an active role in their management is hugely empowering. And so I can say, especially with the patients that I now treat, I have not felt as though they're, reaching out to me in an incredibly large volume to recheck things because they felt that they are progressing, that it really has been a point of empowerment for the patient themselves. Are there any other comments from our group here? Matt, I don't know if you wanted to share anything to Alan.
Matt, you're on mute.
That should work.
There we go.
Sorry. Yeah, I mean, just first, excellent presentations from Irfan, Sonia, and Jenny. Thank you for sharing. And it's both exciting and daunting, to Amandeep's point. We already have, I think, a fair amount of data in glaucoma just with our testing we do. OCT has become much more analytical. I think we spend a lot more time even now than I did as a resident. We already had the perils of visual field. We all know how difficult it is to interpret visual fields, and we all know that the eye pressure bounces around. And now we can potentially do all of this in much more real time if people start doing this at home. And as much as many people are empowered, I do have some patients where I worry that it's ruining their life, that they are overcome with anxiety, and that the treatment and monitoring has become worse than disease, because many people don't go blind from glaucoma. Some days it seems like they are all going blind. And in that sense, we have to be careful, but not everyone is, and they have been overcome. So, I wonder, at least for now, it's more of a niche. I call them hypothesis-based testing. So if you have a patient who you're worried are fluctuating, so for instance, pigment dispersion glaucoma, I'm a young guy, if I was a little more nearsighted and I had pigment dispersion, I think they should do it. I think they should do all of their physical activity and be checking their pressure. I recommend it to them, and yes, I pass it, if they want to buy it, I think it's reasonable. Angle closure patients where we're not going to do anything, I think it's also important. They may not need to do it all the time, but they should probably do a good hypothesis test to see if they're fluctuating. And pretty much anyone who we're calling normal tension glaucoma, I think they should have a test to see if it's really normal tension glaucoma, and you'll be shocked. A lot of those people are not normal tension glaucoma, and they're being seen every 6 to 9 months, and they actually had a lot more fluctuation than you thought, and it's just going to take way longer. I think it's same on the visual field. We know that there's rapid progressors and we know there's slow progressors. So I think for most people, it should be a concentrated time where we make sure that patients are not going downhill quickly. And then hopefully their anxiety lets them to lay off, and we can give them guidance that they don't have to be doing this, does not have to consume their life. And for most people, I don't think it will. I think we have evidence, for instance, in the blood pressure. There are some patients who are wearing Holters all the time, but it's very rare, right? In fact, in the diabetes area, I think by and large, we want people to be checking their blood sugar more, don't we? And they don't. So I don't think we have to be so paralyzed by this where we just stop all progress. I think we have to go in and still be the leaders in it, because that's the other problem. If we just shun it, and this has happened to me too, it's like when I tell the patient I don't think they should buy one, I almost feel like that gives them more, then they're going to Europe and buying one like right away. So you work, you tell them no, or you work with them with where they're at. And I think we have to move to that. But the amount of time and the amount of data, it is daunting some days. When they come in, I'm sure many of the general ophthalmologists experience it too. They come in with their folder of all their eye pressures or all their visual fields that they've taken, and it's a lot.
Now, Matt, is there, AI is really excellent. The neural networks and the deep learning is really excellent in seeing trends. It's overwhelming when you've got a full office and they come with folders. Is there a role for AI built into these machines, or some way that you can evaluate that in a more expeditious and effective manner to allay the patient's fears, or alternatively say, yeah, you are progressing. I mean, there's a lot of data there, and you're responsible if it's your patient. Is there a way of harnessing the power of AI to evaluate that? Almost like Sonia said before, you know, it'll review the things that you may not understand, and maybe it's really good at picking up trends. So is there any like potential use there or direction that might be going in?
Yeah, I think the short answer is yes. It's just going to be the devil's in the details. For instance, I really like the AI that's helping to enhance our resolution. So I use in the OCT space this concept that we need to be radiologists, not stockbrokers. Stockbrokers just look for red and green, but radiologists make sure they actually understand what's going on. And I think that the fear is that AI is going to turn us all into stockbrokers. Glaucoma Workplace has this printout where it just shows you green checks and red X's. And I wish that they would completely eliminate it, because it is probably wrong most of the time. And it's not helping anybody. Okay. It's of course what we all want to know, yes or no. But you know, that's why there's physicians, and that's why there's an art of medicine. And that's why we're not going to not have a job anytime soon. So I like the enhanced resolution ones. I also like the promise where it seems like AI. I kind of think of it like a car. So I don't know if I want my car to drive me fully yet, but I love all the beeps and warning signs, the fact that my vehicle will slow down if I'm getting close to someone, the lane departure warning. I want those kind of things as part of it. So I want the heads up for that first visual field, right? We know from OATS, 87% of visual field defects go away over time. Well, AI can probably help us to say, flashing light, this one might be real based on millions of data points. I would like that, as opposed to the folder and getting the Zeiss Glaucoma Workplace check marker X. I think we're going to do ourselves and our patients a disservice if we try to get to there. And of course, we're not necessary anymore. We might as well have technicians or nurse practitioners reading X's and check marks. If our algorithms are that good, fine, we can be replaced. I highly doubt that's happening anytime soon.
So you're saying you want them to make us to be a better driver rather than drive us.
I like that.
Mm-hmm.
Well, Natalie and I were just laughing because we know Matt well, and we think he used to be a stockbroker in a past life. So, well, I apologize. I cut off earlier. Something happened with the internet in the building, but I do want to thank everyone for just a wonderful round and some engaging discussion. It's quite exciting what the future has in store for us, and I do hope that VR and AI augment what we do and allow us to serve our patients better. So thank you, everyone. And Matt, thank you for joining the discussion. But Sonia, Jenny, and Irfan, those were wonderful discussions. These are our last rounds for the calendar year, so I do hope that everyone has a wonderful holiday season with their families. Merry Christmas, Happy Hanukkah, Happy Kwanzaa, and whatever else everyone is celebrating. I do wish you have some time to relax and kick back, as Sonia said, with the ones that you love. So enjoy this time, and we'll see you all in the new year.
Thank you, everyone. Take care.
Great presentations, everybody.
Yeah.
Very nice. Thanks. Yeah.